as our studies open back up, we are slowly moving back into the research world. So we're creating other ways in which to screen patients and support our staff so that, we can keep those things in place even with fewer people at the bedside.
Today on Cancer Buzz, immunotherapy clinical trials during the pandemic. How programs are working to keep treatments moving forward for patients with cancer. What you need to know is next. Even in the face of a global pandemic, cancer care professionals continue an unshakable commitment to their patients. Part of that is keeping patients moving forward in their treatment and searching for clinical trials that could help. Immunotherapy clinical trials are vital to advancing cancer research, and they may be the best treatment option for some patients, but the pandemic has made it difficult to continue these trials for many reasons. Factors including travel restrictions, new constraints on patient finances, and new demands placed on program staff have forced many trials to be paused, postponed, or canceled altogether. In a recent survey by the American Cancer Society, half of its funded researchers report that their work has been placed on hold since the beginning of the crisis. You heard from Joanne Riemer earlier in the show. She's a research oncology nurse at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins in Baltimore, which has created a COVID command center. The Johns Hopkins Oncology program has found a way to not only continue conducting trials during the pandemic, but also plan for future ones.
We very quickly looked at many of our studies and started to question the risk versus the benefit to patients by continuing them on study. We've then had a lot of guidance from both our IRB, we have a COVID command center, and I believe they're taking a lot of their cues from federal agencies and the CDC as to how to move forward. So a lot of our studies, either patients were delayed if that was in their best interest, or did not come on study, went on standard care treatments, or the studies themselves were put on hold. So we do have patients that are still being treated on study, but the numbers are much less than they were before this all occurred, or before about March 15th.
Pre-pandemic, how many studies did you have going? How many patients were in those studies? And then how many did you have on deck? And of course, what does that picture look like now?
Well, before this, we have 4 nurses at my location, and Johns Hopkins has multiple locations. We have studies both at the downtown campus, at the Bayview campus, at Sibley, and perhaps at some other areas as well. And in my area, I was handling about 12 studies. Some of them, not open to accrual, and some of them just getting started. But it's kind of hard to say. But as a group in our downtown location, we probably accrue 100 patients a year or more. And that's just in my small little group. But I got deployed middle of April. So I am now in a clinic working with patients. So for me, it's changed my role tremendously. But the thought is that I will be pulled back into the research group as soon as we're allowed to open more studies. And that is rolling out actively right now.
How do you recruit for new studies right now?
A lot of language that is being placed into studies had to be generalized so that we're all speaking the same language, we're all practicing the same protocols in regard to COVID and how we're screening and how we're reporting and documenting. And we're being told that that is developed now and should be rolling out this next week. So as soon as that is put in place, then we can begin the process of enrolling. And that will be a slow rollout. So, they're deciding which studies we can open first. And these are all being coordinated with the command center as well as IRB to make sure that we can move forward safely and not overwhelm, different groups with these new processes and procedures.
Clinical trials are a very emotional thing for patients. For some, it's a last resort, but for all, there's a whole lot of hope riding on them. As far as managing the anticipation for the patient, with the realities of COVID and the current situation, which is emotionally charged in itself, who's in charge of handling that with the patients?
Well, there's a lot of communication that's going on. We have my chart messages that are going out for general information to patients. Providers are having telecommunication appointments, as well as the research nurses are. We're trying to make patients feel safe too, because there are some people that are afraid to come out and afraid to come to the hospital because of exposure. And so, we're informing them of the processes that are in place with the no visitor policy, unless there's an extreme circumstance that requires approval. There is screening that's taking place the day before every visit and at the door. And then a lot of telecommunication that's taking place for visits that don't have to be in person. In the treatment areas, since I'm there now, I can see the cleaning processes that are going on and the separation that's going on in waiting rooms and in treatment areas has really increased to try to make patients feel much safer. There are patients that have tested positive for COVID. And so we have units that are specifically dealing with those patients because, some of them, even though they're positive, they still need their treatments. And so we have areas that are treating patients with anti-cancer therapies in a unit that has negative pressure and staff specifically trained dealing with this disease.
Are your studies affected at all by travel restrictions or the unwillingness to travel?
What we've tried to do is, try to stick, if we can, within the plus or minus days of the study. But there have been some people that have missed more than one treatment because of either the situation at the hospital or whether we were allowed to bring them in. And so we're documenting those and working with the providers, and the sponsors have been very understanding. So they're listed as deviations, but the reason being COVID. And I don't know on their end how it's affecting their evaluability in the study.
For IO patients in particular, symptoms of toxicity look very similar to coronavirus symptoms, such as shortness of breath, coughing, and chest pain. What are you using to distinguish between the two?
Well, we've been very fortunate. We have an immune-related toxicity team that's been very active and helping to screen patients or help providers deal with toxicities that come up from these different checkpoint inhibitors. And one of those, the providers on our IR Tox team is Dr. Jeruska Naidu. I think she's been on your program and different webinars, and she created an algorithm to help differentiate pneumonitis symptoms versus the toxicities from COVID. So it's been very helpful. It's not an easy thing, but there are some differences that are beginning to show themselves.
We're all bracing for a second wave. Maybe we're in it now, or perhaps we're still in the first one. Are you making any preparations in your studies for the fall?
Well, I don't think we're going to let down our guard. I think we're going to keep, the mask and the cleanliness and the hand washing in place. I don't know if that'll be enough, but when it first revved up, we weren't doing all those things. So I'm hoping it will be helpful. The other thing that's happening is a lot of our research nurses were deployed into the treatment areas in anticipation of an increased need of staff. As our studies open back up, we are slowly moving back into the research world. So we're creating other ways in which to screen patients and support our staff so that, we can keep those things in place even with fewer people at the bedside. Some of the electronic alerts to patients, getting them to answer questions the day before they come in. So maybe we can be prepared for some of the symptoms or side effects that may redirect their visit to be done in either a negative pressure room, or to at least have somebody meet with them and ask some additional questions to see if they need to be screened for COVID on arrival, and not have them enter into our treatment patient area.
Do you anticipate any changes or a hit to accrual going forward as a result of this pandemic?
I think people are still very interested in trials, and I think trials are necessary. I think the language will change. I think all this communication has been fabulous for trials. The way that we're able to communicate more remotely, maybe we can consent more remotely. I think some processes have been put in place that are very helpful for clinical trials. I know at Hopkins, some of the medications that are by injections or oral medications have now been able to be sort of drive-by. We have patients that come in, they pull up to the center, they get weighed, they get their vital signs, and then they either get their injections or their tablets. They exchange documentation, and then they go. They don't even come in the building. So people like that, and they continue that service if it, is well received.
Finally, talk to your colleagues. What can programs do to keep studies running, even though we're smack dab in the middle of a pandemic and we have no end in sight? How do we continue to keep studies running and recruit new patients?
Well, I think it's communication and documentation so that we can explain these breaks. And with the toxicities, we need to include screening of COVID in our evaluation of patients that are on IO. So I think, before COVID, we thought everybody that had a cough or short of breath probably had a toxicity from checkpoint inhibitor, even if they had pneumonia. And now we think everybody's got COVID and we forget about anything else. So I think we have to continue to look at our patients and keep all of these things in mind as when we're doing differential diagnosis for symptoms that occur while our patients are on trial. But I think as long as we communicate and document, we should hopefully in the very near future be able to open up some of these trials and offer them in a safe environment by continuing the diligence of screening patients and communicating with them about the risk.
You can find more resources about immunotherapy clinical trials during COVID in the show notes, including the FDA's guidance for conducting clinical trials during the pandemic. Thank you for listening to Cancer Buzz. We hope you're enjoying the show, and we would appreciate it if you would take a minute to subscribe in your favorite podcast app, and then give us a review and share the show with your colleagues. Reviews help us continue to bring you more information on the latest in cancer care. Next week, we'll discuss how you can develop a COVID-19 testing strategy for your cancer program. Until then, for the entire Cancer Buzz team, I'm Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.